cords, what is that? The larynx, yep. This is just, this doesn't describe anything specific, it's just a location I put in there. Section of the pharynx at the back of the throat from the soft palate to the U-shaped hyoid bone. Yes, it's gonna be part of the oropharynx. And then you have the nasopharynx, which is the combination of the two. Alright, adequate and inadequate breathing. Those are your two main types of breathing. You have adequate breathing, you have inadequate breathing. Under adequate breathing, there are two subsections, okay? You have normal breathing, which is adequate, and you have respiratory distress, which is adequate. Respiratory distress is just when there's a little bit of a stressor applied to the respiratory system, but they're still able to maintain the function that you need in order to bring in oxygen and get rid of CO2. Think of respiratory distress like you work out, right? You go on a workout, your respiratory effort increases, you're not gonna drop dead because you can't maintain, life at that point. You just have a stressor applied to your respiratory system. That's still gonna be considered adequate breathing. Inadequate breathing is gonna be any type of breathing that will not sustain life. So there'll be respiratory failure and respiratory arrest. A little bit later, we'll talk more about those, but those are your two main types, inadequate and adequate breathing. Some things that you can keep in mind, generally, if your patient has a mental status of, they haven't lost their mental status, they're still cognitive, they're still talking, anything like that, they probably have adequate breathing. It's when they start to decline and lose their mental status that we now go into inadequate breathing, whether it's respiratory failure or respiratory rest. The fact that they're losing mental status is a concern here. So here, an increased effort to breathe, increased depth of respiration, pink, dry skin, and sitting upright answering questions. If they're able to sit upright and answer questions, they're considered to not be altered. Like they're talking to us, I walk in, this person is sitting there looking at me, asking something to talk to me. Even though they're breathing, they're not breathing inadequately, okay? If they start breathing inadequately, they're probably not sitting up answering questions. And this one, rapid breathing, dry skin, but a normal mental status. This is another reason why we would not think that the breathing is inadequate. Their mental status is normal. There is, well, I'll tell you all that one later when we get to another question that has it. This one I tried, y'all, to describe someone who was sleeping, and I'm glad nobody picked that, okay? Technically, if you're sleeping, like you are altered, I get it, but you should respond almost immediately, when someone starts talking to you. Good there. All right.
Haley, prove it. Carol.
Oh, wait.
Got it.
So last week, we posted a paper version. Are you
Taylor Payne.
doing that again, or is it?
Yeah, I'll post the paper version.
Okay.
Yeah. All right, let's talk about this one. First off, before I even get into the answers, is this patient breathing adequately or inadequately?
Inadequately.
Inadequately. If your patient is breathing inadequately, oxygen will not fix the problem, okay? You can give oxygen, but you're not gonna fix the problem with oxygen. You have to do something else, okay? So if they're breathing adequately and you wanna you can give them oxygen. You know, if they, again, you went and worked out, okay? You can get a little bit extra oxygen after that, you'd be fine. But if the breathing, if you determine that the breathing is inadequate, oxygen alone is not gonna solve your issue.
Well, here's the deal. What's the normal adult rating?
12-20.
12-20. Is that lower or higher?
Low.
Okay. There's no oxygen, no nasal cannula, no non-rebreather. Oxygenation means non-rebreather, nasal cannula. Bag valve mask ventilation for shallow, for anything outside the value, high or low. Okay, that's low BVM. That's the only answer you're looking for. So for 26%, to only get it right out of that green, right? That's a major issue. You've got to correct your thinking.
The other thing I wanna point out, and this is something I came up with, y'all, with on my own, you're not gonna find this in a textbook. I call it the 8-28 rule. It works about 95% of the time, okay? If your patient is breathing 8 times or less, or they're breathing 28 times or more, they probably need to be ventilated, okay? 8 times or less, or 28 times or more, they probably need to be ventilated. Okay, that has about a 95% accuracy rate. I'm not gonna say 100% because I guarantee you someone will find the one patient that's breathing 32 times and they're just fine, okay? The 8 or less, or 28 or more, they probably need to be ventilated. The other thing that you need to keep in mind is, so 2 of these, let me back up. So we can eliminate this answer: transport, apply oxygen via non-rebreather, 12 liters per minute, and warm the patient up. Those patients need to be transported, yes, I would agree that we should transport that patient.
Okay. Jackson County. Hey, anybody, day class, everybody got your shirts? Any issues? Okay, very good.
But this says nothing in here about fixing the respiratory rate, so that's why this one's out. All we're doing is giving oxygen for this patient, right? This one, place the patient supine, administer oxygen, perform a jaw thrust, and transport. These 2 things are rarely done in conjunction. If I'm performing a jaw thrust, I should be ventilating the patient because I'm opening the airway. If I'm determined that I need to open the airway, then I probably need to put air into the airway, okay? Again, this one does not say anything about actually ventilating the patient. Yes, this patient is in a state of shock. You do need to treat them for shock, but our issue here, if you remember, we do ABCs, right? Where do I treat for shock in my ABCs? In the C, in the circulation, right? I'm addressing all of my circulation issues, but I haven't done anything for my breathing issues there. Okay, I've gotta fix my breathing issues before I can get to my circulation issues. So that's why we're eliminating, this one. Suction the airway as needed. I don't see any, well, yes, snoring respirations. I don't have any indications in here that he needs to be suctioned, but if he does, we would suction the airway. You then place an OPA and ventilate the patient at a rate of 10 breaths per minute. If you have multiple things that need to be done, so let's say you need to suction, okay, we know that our patient needs to be suctioned. Snoring respiration, so we know we're gonna have to place some sort of airway, whether it's an OPA or an NPA, right? Say we need to do some sort of maneuver, whether it's the jaw thrust or the,
Chin lift, head tilt, chin.
yeah, head tilt chin lift, one of the 2. Jaw thrust or head tilt. Alright, and they need to be ventilated, okay? We've determined that our patient needs all of this stuff done, okay? Order matters. I can't just randomly start doing things. Before I want to breathe for the patient, I want to make sure that whatever air I'm putting in the patient is not going to carry whatever foreign object is in the patient's airway down there. So I have to suction before I BVM, right? Before I suction, their airway has to be open, okay? You can't suction a closed mouth, right? So before I do that, I want to have an airway placed, okay? Before I place an airway, I actually have to open the mouth, okay? So this, if you have options of what you need to do in the order you need to do them, if this is one that you need to do, this one's probably done first. This one's second, and I didn't mean to write them in that order, it just happens like that. This one would be third. and this one would be fourth, okay? All of them need to be done, but the order matters. You can't BVM a patient before you open the airway, okay? You can't place an airway, you can't suction the airway before you placed. And actually, I think, if I'm not mistaken, these are actually gonna be reversed.
Okay,
Yeah,
that's
this
what I
would
was
make more
trying to think
sense.
about.
This would make more sense, it would be like that, there you go. But you would do that, suction, place your airway, and then BVM, alright? Cause you'll have questions on your test where all of those seem like things that you need to do. But what's your immediate next step? What have you done? What's the immediate next thing that I need to do? And you just kind of rank them like that. Yeah, she came in, you came in, you just came in, right? Yeah. Are you still answering, Mary? Hold on. Okay. I'll give you a couple more seconds before we move on. There we go. Alright. Most of us got it right, I'm good, I'm gonna go down to the answers. I don't wanna see the whole question. Alright, so what is our answer?
Ventilate.
Yeah,
Okay.
ventilate, okay? First, before I even get into all of these, up here, when we're describing her breathing, is it adequate or inadequate? Initially, she had adequate breathing, right? She's talking to us. Now granted, her stats are low. We can fix that with oxygen, okay? But she's talking to us and we don't really seem to have any issues, so we have adequate breathing, we'll move on. Adequate does not necessarily mean normal, okay? Don't get that in your hand. Adequate can be normal, but you can also have adequate breathing that's not normal breathing, okay? Remember, there's two types, adequate and inadequate. Adequate has two subsets, normal and respiratory distress. All right? Her breathing, she ends up becoming barely staying awake and respiration slowed to 8 per minute. Go back to my 8:28 rule, she's 8 or less, so we know we're gonna need to ventilate her. Do you have any indication in here that she needs to be suctioned? No gurgling, no nothing, so suctioning's not something we need to do. Why is this one out? First off, what's an indication for a medium dose inhaler?
Asthma, anything like that.
Wheezing, yeah, something like that, we don't have any indication that stays. Plus, what does my patient have to be in order for me to use that? Conscious and follow commands, right? She's barely staying awake, so we don't need to do that. And now, increasing her oxygen is not gonna solve the issue, because at this point, what type of breathing does she have? Inadequate, and oxygen does not fix an inadequate issue, okay? A couple other things I wanna point out with this. Do y'all I don't know if y'all gotten into this, I can't remember where this is covered in the chapters, but a pulmonary embolus, what risk factors do y'all see in here that, for a pulmonary embolus?
Status post, hip surgery.
Yes, the status post-op hip fracture. Patients who are immobile for a period of time after a surgery, or, I had it on a patient one time that they traveled like 15 hours straight from somewhere up north, they were coming down here for a vacation, and they only like stopped the vehicle and stop at a gas station, use the bathroom, otherwise they were like immobile in the sense that they weren't up walking around. The patients who are like seated or laying for a long period of time, or they've had a surgery recently, or something to that effect, increases their risk of developing a PE, okay? And the other thing I want to point out, when you get to reassessment, what is the first step of reassessment? Yes, repeat your primary survey. What is the first step anytime your patient starts to deteriorate? You reassess, which is repeat your primary survey, okay? If your patient starts going down, repeat your primary survey starting with ABCs, okay? You don't need to do another set of vital signs. You don't need to give another medication, okay? Your patient has changed. Why have they changed? Let me start with my ABCs again. There are multiple answers on here. Good, so it does eliminate the need for manual positioning. You don't have to do a head tilt, chin lift, or a jaw thrust to place an NPA. It is actually contraindicated in a head injury. If your patient has a severe head injury, probably not gonna use an NPA. Part of the reason is you don't know the extent of the trauma with the head injury. I mean, you don't have X-ray vision, you can't look at the skull. You can see outside, but you can't see inside, right? And, the top of the nasal cavity is the floor of the cranial vault, and you don't wanna end up, you don't know if that cranial vault is damaged, you don't wanna end up like poking into that with an NPA. So we don't use an NPA on severe head injuries. It is ideal for patients with locked jaw. It may be tolerated in patients with severe gag reflex. And it is contraindicated if a patient has a nasal fracture. If their nose is broke, we're not sticking anything in their nose. So the advantages are these three. Eliminates manual positioning, ideal for locked jaw, and good for patients with a gag reflex. Alright, good. Primary assessment begins by serving patients as you enter the room. What is that called, by the way? What are you forming?
Initial impression.
Your general impression, yes, your general impression. Some test-taking strategies, and it's not just this question, it's test-taking in general. Anything that is an absolute is probably not your answer. For example, manual airway maneuvers must be performed on all patients. That means that there is no exception to that, okay? That means every patient, you are doing a head tilt chin lift or a jaw throw. Is that the case? No, there are patients that I do not have to do that for. So I can probably eliminate that answer because absolutes are not likely to be the case. Is external bleeding always obvious? No, it's not. And then here's the other one, is the EMT should perform a sternal rub on all patients to test their response to painful stimuli. No, it's not all patients you have to do a sternal rub on. Sometimes you can, pinch their finger or something like that. It doesn't have to be a sternal rub. All right. But that is the general impression, and that's when the primary survey starts. Yes, open the airway with a head tilt chin lift. Does this patient need to be suctioned?
Yes.
Yes. Can you suction the airway before you open the airway? No. This right here. What part of the primary survey do you check a pulse in? A, B, or C? C, right, in my circulation. Where am I at in my scenario? A or B, yeah. We have gurgling, we're managing the airway, which means I'm not to circulation yet, okay? If you have a problem with your ABCs, you do not move on to the assessment until you fix the ABC problem, okay? There are, and I'm sure y'all talked about, there are like 2 times where you will do a CAB assessment, but almost all the time you'll do an ABC assessment, okay? If I find an airway issue, I'm not assessing a circulation issue. I'm fixing or managing my airway issue, then I'll move on to a breathing issue, then I'll move on to a circulation issue. But I'm not checking the pulse if my airway ain't open, okay? Because that circulating blood isn't gonna do me any good if there's no oxygen in that blood, okay? For those of y'all that put suction in the airway, you're not wrong. Like we said, you do need to suction, but think about it, you have to open the mouth before you can ever stick anything in the mouth to suction it out. What about 17? Somebody else show up?
No, I had, got off my phone and got on the tab, so
Which one do I need to
Asian
delete?
and didn't take out free.
I don't see the
We
one.
under attempted.
Huh?
Be under attempted.
That one, I can eliminate that one.
Yes, ma'am.
is a sign. What is the difference between a sign and a symptom? A sign is observable, okay? It's something that you can see, you can point to and say, yes, that is a fact that is there. A symptom is gonna be closer to something a patient describes. A patient can say that they're in pain, you can't see pain, okay? Now, you can see them doubled over and guarding their stomach and assume that they're in pain, but you can't see pain. That would be a symptom. A sign is something you can see. Vital signs, those are things that you can observe, right? I can observe a blood pressure, pulse rate, respiratory rate, anything like that. What is the field impression?
The diagnosis.
Yeah, field impression is closest to the diagnosis, right? Don't get field impression mixed up with general impression. General impression is done at the beginning in the primary survey. Field impression is done at the end. Field impression is what you are treating. After your full assessment, you determine your patient's hypoglycemic and you're gonna give them some, glucose, right? That's your field impression, my patient's hypoglycemic. Field impression is like the diagnosis. General impression is that initial, sick, not sick, are we doing good or bad? Complaint or chief complaint, that's what the patient says they're complaining of. And then again, symptom is something that the patient's telling you, it's not necessarily something you can observe. Good. This patient is in respiratory distress. Here's what I was going to show y'all. Here. So, in your two types of breathing, inadequate breathing, that way, you have adequate breathing. I'm not spelling all these words out. In adequate breathing, you have normal breathing, and you have distress. Okay. In inadequate breathing, you have failure, and you have arrest. Okay. These two, normal breathing and arrest, should be the easiest ones to identify. Okay. How many of you, when you introduce yourself to someone, you're like, "Hi, my name's Kayla Tanner. Are you breathing today?" No, right? You assume that you're talking to someone who is talking back to you, they're breathing, okay? We don't typically pay attention to the fact that someone is breathing, okay? If there is nothing that is drawing your attention to the fact that your patient is breathing, you don't notice it, there's nothing that makes you look that way, or, hey, something's off here, they're probably normal breathing, okay? If there is anything that makes you take notice of their breathing, they're probably in one of these three, okay? If you know, even if it's a sound, if it's a rate, if it's a whatever, if you've noticed their breathing, because it's not typical for us to notice someone is breathing. If you've noticed their breathing, they're probably in one of these three, okay? This one should be easy to identify. Why should that one be easy to identify?
Probably unconscious.
They're not breathing at all, okay? In cardiac arrest, your heart stops. In respiratory arrest, your breathing stops, okay? So there is no up and down of the chest. There is no condensation. You're not going to feel warmth on the back of your hand if you place. There's no signs of breathing at all. They've stopped breathing. The hard part is differentiating between these two, because this is treated with what? Oxygen. This is treated with what? And this? Ventilation. Yes. Oxygen, ventilations. Okay. Your two biggest ways to differentiate is mental status and rate, okay? Again, go back to that 8-28 rule. If they're 8 or less or 28 or more, it's probably failure, okay? If they're up and talking to you like this guy is, or they're able to answer questions, they're able to sit up. I don't mean like tripoding like this. I mean, they're just able to sit up or walk around or whatever. They're probably in distress, okay? If they are declining in mental status, they're probably in failure, all right? Another way to look at the difference between these three, I like to use the example of running a marathon, okay? You have a marathon that you want to run. You've been training for this marathon. You're like, I want to finish this marathon. I don't care how long it is. I want to be able to finish this marathon in an hour. That's my goal. My personal goal is to finish this marathon in an hour. Day the marathon shows up, you've been training, you finish the marathon in an hour, no issues. You finish it in 40 minutes, right? You're really good, no issues. Normal breathing, okay? Day the marathon shows up, you start the race, you're in the marathon, and I don't know, you trip, okay? Your shoelace was untied. You tripped, you had to stop and tie your shoe. You get back up and finish. You still finish within an hour, okay? You met your goal, you finished the marathon within an hour. You just had a little bit of a distraction or something, or stressor applied along the way because you stopped to tie your shoe. That's distress, okay? You start running the race, you start running the marathon, you trip, you have to tie your shoe, you take a wrong turn and you get lost, all right? You get back on track to try and finish the marathon, and by that point, they're like shutting down because you got lost and you almost get hit by a car, whatever. You finally cross the finish line, but you're like, you know, after your hour. It's 1:10, 1:15 that you've been running this marathon. You did not meet the goal. That's respiratory failure, okay? You don't run the marathon at all. You've been training to finish this marathon in an hour, and they start the marathon and you just stand there and you never run it. That's arrest, okay? So if you can think of your 4 stages of breathing, that's how I think of it. If it doesn't work for you, don't use it. But that's how I think of it. These two, I'm getting the job done. These two, I am not getting the job done. What's hypoxia?
That's,
Low oxygen,
lack of
right?
oxygen.
Hypo means low, oxia is referring to the oxygen. There's no such thing as respiratory hypoxia. I mean, your patient can be hypoxic, don't get me wrong, but that's not a class of breathing, it's respiratory hypoxia. All right. Gas exchange. By the way, this is called what when you have gas exchange?
That's respiration.
Respiration. And since it's in the lungs, what type of respiration is it? Pulmonary or external respiration. All right, so this is your answer. Air moves into the alveoli, blood is transported via the pulmonary capillaries, and diffusion occurs. What is diffusion? Molecules moving from high concentration to low concentration, right? Our oxygen molecules are moving from the alveolar sacs into the blood because there's low oxygen levels in the blood, and then our carbon dioxide is moving out of the blood where it's highly concentrated into the alveolar sacs to be breathed out. Why is this one wrong? Osmosis. Osmosis does not occur in the lungs. Osmosis is the movement of what? Water. Osmosis is the movement of water. We're not moving water, we're moving molecules. So it'd be diffusion. Okay? Why is this one wrong? how does blood make it to the heart? Where does it come from?
Not through the left
The right side. Okay, blood is making it, not to the heart, I'm sorry, to the lungs. Blood is making it to the lungs from the right side of the heart. When it's in the left side of the heart, it's going back out to the body. So we can eliminate this answer because of that, and then nobody picked that one. So this is respiration. Specifically, this is external or pulmonary respiration. Still typing. Do a couple more seconds and then we'll move on. Let's see. It is. It is last oral intake. Yes, last oral intake. So when you are doing your patient assessment, there are 2 mnemonics of questions that we ask. Do not limit yourself to these questions, okay? And I think I told you all this when we did the clinical orientation. If you think a question will help you figure out what's wrong with your patient, ask the question, okay? But some guiding questions are based off of the sample mnemonic and the OPQRST mnemonic, okay? Sample, the S is signs and symptoms, okay? In that, you have OPQRST. So when doing your sample mnemonic, when you get to S, signs and symptoms, you ask your OPQRST questions, okay? A is what? Allergies, right? Is your patient allergic to anything? M is medications, okay? P, pertinent history and past medical history, it kind of covers both. L is last oral intake, and E is events leading up to. Why do I want to know the patient's last oral intake? Okay, so if they have to go to surgery for whatever, it is good to know, you know, hey, I ate 10 minutes ago versus I ate, 12 hours ago, so that's good. If you're dealing with like abdominal pain, right? Maybe they have food poisoning. What did you eat? Where were you at? Something like that. If it's a diabetic patient, did you take your insulin and not eat anything? That happens quite a bit. I've seen it way too many times, how you forget to eat. Don't see me eating here, okay? I don't forget to eat anything. But it does happen. You have patients who will take their insulin and then they forget to eat something and you get called out there because there's sugars in their food, okay? So that's another thing. Those are all reasons you would want to know your patient's last oral intake.
You said the M was what?
Medication.
M is medications.
Is it for secondary assessment?
Hmm?
This goes in the secondary.
It's in the secondary assessment. So in the, well, it would be in the history taking, I think.
Yeah, history taking.
Yeah, I think it's gonna be in the history taking, not the, because the secondary assessment's a physical assessment. History taking is where you've got this questions. Alright, the answer is the secondary survey. What is the goal of the primary survey?
Life-threatening.
Identify and treat life threats, okay? I do not care if you have food poisoning if you're not breathing, okay? I've discovered you have food poisoning in my secondary assessment, okay? But if you're not breathing, that's a bigger concern to me. I don't care that you broke your arm if you're bleeding out. I'll fix your broken arm in the secondary assessment. I need to control the bleeding in my primary survey, okay? Primary survey is identify and treat life threats. And then you make your transport decision after that. You have secondary assessment and history taking. I believe y'all did y'all get a skill sheet for this? Y'all, okay, I didn't know if y'all did or not. I believe your book says history taking and then secondary assessment. Okay, in reality, when you're actually assessing patients, you can do those at the same time or one before the other. That's not gonna make a difference. The primary survey has to come first though, okay? So, but then history taking, then your secondary assessment, and then your reassessment, and then field impression evaluation isn't actually a specific component of the patient assessment. It falls within, right after the secondary assessment, where you're like, okay, this is what I think is going on, so let me treat it, and then I'll reassess and see if their response is better or worse or whatever the case may be. But it's not one of the 5 subsections of the patient assessment. And I'm gonna say this again because I've seen this question a few times. What does reassessment start with? Repeating the primary survey, okay? Repeat the primary survey. If you've got to reassess your patient, repeat the primary survey. Yep, cap refill is done by placing your thumb on the patient's fingernail with your fingers underside the patient's finger and gently compressing. Why is this one out?
2 seconds.
It's 2 seconds or less. If it remains blanched for longer than 2 seconds, we have poor perfusion, okay, not adequate circulation. And again, this one's out because it is 2 seconds or less, not 1 second or less, okay? That 2 is included in a normal. So if it's blanched for 2 seconds, it's still considered a normal cap refill time. This one is partially true, okay? Cap refill is a better assessment of perfusion in your pediatric patients than it is in your adult patients, okay? Your adult patients can actually have a normal cap refill and still not be perfusing appropriately. So that's why we don't rely on it alone for our adult patients. what I tell people, if the cap refill is bad, it doesn't matter your patient's age, it's bad. If it's bad for an adult, it's bad. If it's bad for a kid, it's bad, okay? If the cap refill time is good, it's generally more applicable to a pediatric patient. You need other means of assessment for perfusion in your adult patient. It's not as reliable, okay? So if it's bad for everyone. If it's good for pediatrics. It's 2 seconds or less. Still answering, Mary? Okay. Close is quality, it's not quantity, it is quality. Okay, so the P and or the Q is OPQR, is quality. Quality of what? What am I referencing? Pain. Generally, it's referencing pain. The other thing that you can use it for is a respiratory status. So let's go through all of them. O is onset, okay? How quickly or slowly did this happen? You know, a diabetic patient, if they become altered and confused in a matter of minutes versus a matter of hours, then that makes a difference whether you're thinking hypo or hyperglycemia, okay? It can take hours, days, even weeks for a hyperglycemic patient to become confused. Only minutes for a hypoglycemia. So how quickly or slowly are we looking at there? P, provocation or palliation. What provocation, what makes it worse? Think of a sibling provoking you to anger, okay? I'm not touching you, I'm not touching you, they're provoking you, okay? That's what makes it worse. Palliation, think of palliative care, what actually eases the pain or eases the situation. Q is quality. Quality of the pain, describe the pain to me. Is it sharp? Is it heavy? Is it stabbing? Is it intermittent? Is it constant? Okay? They're describing the pain. R is radiation or referred pain. What's the difference, by the way, between radiating pain and referred pain?
Like it travels.
Yeah, radiating pain tends to have a tell, meaning you can feel it travel, like for chest pain, when they say it radiates their jaw, they can feel the pain in their chest and a traveling sensation of pain to their jaw. They feel all the way through. Whereas referred pain, it hurts here and it hurts here, but it doesn't hurt anywhere in between, okay? And sometimes the referred pain may not, the site of the referred pain doesn't necessarily have anything to do with the actual injury or complaint itself. For example, a patient may have like a splenic injury if they're in a trauma, and their spleen gets lacerated, and their left shoulder may also hurt, but there's no injury to their left shoulder. That would be referred pain. Okay. S is severity. That's on a scale of 0 to 10. I don't know. Your book say 0 to 10 or 1 to 10. 0. I prefer the 0. Some people use 1 to 10, but I'm like, if they don't have any pain, you really don't leave them an option for that. On a scale of 0 to 10. The other thing you can use it for, especially like COPD patients who are chronically having a hard time breathing, on a scale of 0 to 10, how would you rate this episode in comparison to other difficult breathing episodes? So I'll use it for respiratory as well. And then time, how long ago did this start? You know, have you been experiencing this for a few hours, a few days, a few minutes? I can't tell you the number of times I get, well, back before Katrina. I'm like, why am I here now? Okay, I understand that you have a lifelong illness, but why am I here now? It all started, one lady, I'm not joking, she said, well, it started when I was born. She was like 60-something. I was like, okay, we're gonna be here a while. All right, but all of these, the OPQRST, are questions that you would ask inside your signs and symptoms when you're evaluating, like you're getting your vital signs or your pain or whatever. They're all related to the signs and symptoms of the sample. And then any other questions that you think is necessary. You're not limited to sample and OPQRST. Those are just guiding questions, all right? If you think it's important to ask when you poop last, then ask that question. Maybe they're constipated, right? They're on narcotics. That can be a side effect of the narcotic pain med, is constipation. So if you think it's important, ask the question. This one's in trauma. There's a lot of mnemonics. I'll give you a hint. We don't use decap BTLS in assessing medical patients. We use it in assessing trauma patients, like it's pertinent specifically to trauma.
I know all the other letters.
You what?
I know all the other letters.
Except for that one.
Yeah.
It's like, you hadn't asked me, I would have known. Taylor? Yeah. Have you answered?
No, sorry,
Okay.
my thing is just not loading.
Is it loading? Are you gonna answer?
I think I have my answer, but it's
Okay,
okay.
I'm gonna go here then. D is for deformity chest. You are not wrong. It stands for puncture. There it is. Stands for puncture or penetration. Either one of those are right. They mean the same thing. Punctures or penetration. Okay. You have deformity, contusion, abrasion, puncture or penetration, burns, any other trauma. That's swelling. Lacerations. L is lacerations. Okay, so like cuts. She like literally anything that you could think of that's happened to the body is covered under DCAT BTLS. Okay, so when you're doing that rapid assessment or even a focus assessment, whatever, on a trauma patient, that is all the stuff we're looking for. To see if we can figure out what's going on.
You said A was what?
Abrasions, like a skin knee, that would be an abrasion.
And what about T?
Yeah.
T,
T's tenderness.
tenderness.
And S? Okay, thanks.
good. It is the time from injury to definitive care, during which treatment of shock and traumatic injury should occur because survival potential is best. It is also called the golden period because there are some injuries where your time frame is less than an hour, okay? So they don't want hour to be like, you know, oh, I'm still within my hour, okay? There are some injuries you have like 15 minutes to fix it or they're dead, okay? For this one, why can I eliminate this answer?
That eliminates all the time before you even got there.
Yes, this has nothing to do with the time frame before you even arrived, right? The time frame that the patient is likely to survive starts from the time of the injury. If it takes you 20 minutes to get there, you're still eating into the hour or period or whatever you want to call it, right? So it's not from the time that the care is initiated, it's from the time frame that the injury actually occurred. Most with severe traumas, most of those patients you want to have off the scene within 10 minutes so that you can make sure you're staying within this time frame. You know, we try to do our ABCs, load the patient on the ambulance, and everything else we're doing en route. Really, the only time you're not doing that is if you have multiple patients and you can't abandon patients on scene. But if you have multiple responding units, hey, this is a high, you know, multi-trauma system patient or whatever, ABCs from the stretcher, y'all go to the hospital. And that's just not the answer. It's not really, that's just not the definition of the term. All right, for this question, you list the, you ain't gotta type them out, like whatever order you're putting it, you just type the number. Number, comma, number, comma, number, no spaces.
Is that all of them?
Yes, this is all of them. Do what?
Are we gonna take a look?
Yeah, we'll take a break after this one. I'm gonna go to the bathroom. It is 3, 4, 1, 5, 2.
I did, they say I got it wrong.
That's what I got.
So if you didn't do number, comma, and you had spaces in there, it's not counting it right. That's
I did number comma.
It had nothing to do with the order.
I think
it's
you might
literally-
You said 3, 4, 1, 5, 2.
It's no comments, that's why.
I have no. Oh, well,
Yeah,
I'm
the
sorry, I
correct
messed you
answer
up.
says no comments.
Oh, no.
My bad. The order is what
That's
I'm
what I'm
concerned
saying.
about. I don't care about the
Can you
comments.
say the order one more time?
You said 3, 4, 1, 5, 2.
Yeah, it's 3, 4, 1, 5, 2.
Yeah, I got it right.
So that's the order. Comments or no comments, that's the order.
We
All right, y'all, we're gonna take a quick break. I gotta finish some stuff. We'll get back and we'll come back and finish this.